Hello, Professor Vito. Nice to see you here. And right now, it's my honor to have to host this course. The first, I'd like to introduce Professor Xie, and she is a professor and the chairman and the Department of Medical Ultrasonics from the first affiliate hospital as Sun University. She is a very famous professor in China and have published a lot of SCI paperwork. And she's charging measure is CEUS in the liver or some superficial organs. So it's our pleasure to invite Professor Xie to have a presentation right now. Professor Xie, please.
Hello. Let me start the lecture.
Yes.
Okay, thank you. My topic is focused on the application of CEUS in small focused liver lesion. I'm from Guangzhou, China. My name is Xiaoyan Xie. Liver carcinoma is very often in China because the etiology is related to the hepatitis B infection, and the morbidity is number 4 and the mortality is number 2 in China. But now, by use the contrast CT and contrast ultrasound, the small tumor are detected very often in our clinical practice. So now the hot topic in China is how to diagnose the small HCC and how to treatment the small HCC. By recent year, we use the new technique, contrast ultrasound, enhancement ultrasound, is very useful in our clinical practice. So today, I'd like to say something about the CEUS. Firstly, I'd like to say why we use CEUS in our clinical practice. It's CECT is not enough in diagnosis, or color Doppler image or CEUS have the similar effect, or how and what the rule of CEUS will be in our clinical practice. So firstly, I'd like to start my lecture from a typical case. This is a female patient, 61 years old. He got gastrointestinal cancer, and with a liver metastasis, the size is about 2.8. So the hospital have a big consultation. It's focused on the diagnosis of liver mass and the treatment of liver mass and the timing of the gastrectomy. So at the last, the consultation conclusion is the follows. First step is the chemotherapy 4 to 6 course to reduce the tumor size in liver, and then we use the CCT to evaluate the treatment efficacy. If the tumors become smaller, and we use the tumor ablation. For this patient, we can see the tumor is very close to the bile duct. So if the big tumor have ablation, the bile duct will maybe damaged. So by the conclusion, what we will do when we should wait for 3 or 4 months for the chemotherapy, and how to monitor the chemotherapy effect. It's only by CT, so we used to contrast ultrasound. But by the first course of chemotherapy, we found the tumor is become smaller, and with a few perfusion, after the second course of the chemotherapy, the tumor is become more and more smaller and few perfusion, and it is separately from the bile duct. Bile duct is here, so it's good news for ablation. So we remember we plan waiting 4 or 6 calls for chemotherapy after the CEUS contrast monitor. The second consultation it's happened. The conclusion is to stop chemotherapy and to ablation immediately. So we can see the contrast ultrasound is very important in the clinical practice. So today, I'd like to say some about the CEUS in the small liver tumor. We can see the follows. The CEUS is useful in differentiation diagnosis for tumors, and it's helpful to locating or to detecting the small HCC in liver, and it's helpful to evaluate or follow up after ablation efficacy, and it's helpful to guide the tumor ablation puncture, and it's useful in evaluate or monitor the taste of chemotherapy. So I will talk about next step by step. Firstly, it's about the differentiation diagnosis for tumors. In this picture, we can see a lot of tumors. It's difficult to diagnose which one is HCC, which one is the hematoma, and which one is others. So we use the contrast ultrasound, we can get more information about the enhancement time, arriving time, watch time, or the enhancement level. And then we can get enhancement shapes for homogeneous, inhomogeneous, or donor side, or centripetal fillings. It is very typical, and we can see the enhancement change pattern from hyper-echo to hyper-echo, and to hyper to hyper, and to hyper to hyper. It's helpful to observe the enhancement change for after the injection. So for the typical case, we can see the HCC is fast in the artery phase and fast out in the portal phase. And the hemangioma is a typical centripetal fillings, so it's easy diagnosis for doctors. So CEUS, the advantage is including its real-time, continuous image, and objective information, and diagnosis confidence bring to the doctors, and no toxicity and no X-ray. It's very useful. So by use the contrast by risk table, we can see before use the contrast, the diagnosis rate is about 26 to 71, 72. By use the color Doppler, we cannot change diagnosis rate very much. But when we use the CEUS, the diagnosis accuracy is right about 20% to 30%. It's very, very helpful and useful in the for the diagnosis and the differentiation diagnosis. The second I like to say is the CEUS help to locating or detecting the small HCC tissues. This case is 15 years old male patient. He get hepatectomy 15 years ago, but now he get AFP elevated. It's about 16.4 nanogram. But firstly, I used the 2D ultrasound. I cannot find tumor where it is. I used the contrast ultrasound. I cannot find it too. I used the contrast CT, the same. We cannot detect the tumor. But when we use the UV MRI, we can see the tumor is here. So according to the MRI, I go to the second contrast ultrasound for the patient in the portal phase. I note a low enhancement area in here. I think it may wash out area of the tumors. So I give the patient the set contrast ultrasound and observe the fast in here is the artery phase in high enhancement. So we can see by use the contrast ultrasound, it's very, very easy. It's very useful to find the small tumor, and we can see the tumors that cannot see in 2D and sometimes in CT. Another case is you can see the left picture, and in here we can see only one tumor in 2D ultrasound, but by used contrast ultrasound, we can see 3 tumors here. So we can treatment the 3 tumors in same time. If you use just only 2D, you will miss 2 tumors. It's not good for the patients. And another patient is a 62 years old patient with hepatitis B for 13 years, and he got a recurrent HCC after the RFA 1 year ago. Now he got AFP elevates. So by first contrast ultrasound, we cannot see anything in the tumor, and only the ablation area in the second 7, the same situation in the CT. But in CT, a new lesion is observed in second 7. Here is the new lesion in the artery phase, and we can see the washout in the Provment phase. According to the CECT, we find the tumor here, and it's very small one, just about 1.5, and the enhancement wash out in the Provment phase. So it's very surprising news for the patients and very good news. So by our knowledge or by the papers, it's about 20% of the patients can be change the diagnosis after use the contrast ultrasound. Sometimes in the tumor size and sometimes in the tumor's numbers. So it means about 25 of the patients is needed to use the contrast ultrasound before the treatment to diagnosis, to actual diagnosis. The next one is about the evaluate and follow up after ablation treatments. So by use the contrast ultrasound, we can evaluate after evaluate the ablation treatment immediately. This picture is shown before treatment enhancement in the liver, and the middle picture is shown the 2 needles just puncture to the tumors, and then we have 12 minutes ablation. After ablation immediately, we the contrast agents in injection, we can see a big area is covered the whole tumor area. So it's a complete ablation. So we can evaluate the treatment efficacy immediately. And in this case, we cannot see anything in 2D and cannot see anything normal in the color dot, but by the contrast ultrasound, we can see a big ablation area and a small research tissues in the side of the tumor. So it's very useful for the researching or the local tumor progression tissues to detect to location. So this patient is a incomplete patient. By our data, and we have a multi-center study. The research shows about the comparative the result of CECT or MRI with the contrast ultrasound. The consistent rate is about 98.8. This data is our early stage data, but now more and more cases correlation, the rate is maybe 19%, but it is about 90%. And the fourth one is I like to say the guidance the tumor ablation puncture sometimes is very helpful. For just I showed the picture for you and before this picture, if without contrast ultrasound detecting, we cannot puncture the tumor actually, and so it's the only way by use the contrast ultrasound to display the tumor and to precise puncture. And sometimes the tumor cannot detect by 2D because the ISO and echo. By this case, we can see that by MRI, a 2 centimeter tumor is here, but we cannot detect the tumor by color Doppler and by pre-ultrasound. By use the contrast ultrasound, it's easy for us to display the tumors, and then we can puncture the needles and precisely into the tumor, and then we can have a very effective ablation for the patients. And by the data, the ablation guidance by contrast ultrasound is about 25 cases. It's needed contrast ultrasound guidance, including the small HCC. Sometimes it's in the ISO, in ISO echo, or the residual tissue, or the local tumor progression areas. It's very important by use the contrast CT, contrast ultrasound. And the third one, the contrast ultrasound to guide the puncture, is guide the puncture to blocking the tumor's feeding artery to make the ablation is more effective. As we know, the tumor have one feeding artery or two feeding artery in usually. If we can show the feeding artery very clearly, just like this picture, we can blocking the feeding artery and to reduce the tumor perfusion, and then can make the ablation more effective. So I have a case here. Here is a 41-year-old patient. The tumor size, recurrence new tumor size, is 3.2 with feeding artery with CT. We can see the feeding artery here, and then we use the color Doppler. Maybe here is the feeding artery. So we can get the pulse wave in here. So we use the contrast ultrasound. It's 4D contrast ultrasound. We can see very clearly feeding artery from here to perfusion the whole tumor. So we pray to cut the blood supply from the root of the feeding artery to, and then after that to ablation the tumors. This picture is shown before the ablation, the contrast ultrasound enhancement, and here's during the feeding artery blocking here, and after the 2 minutes artery blocking, you can see a hole, just no any blood perfusion in the whole tumor. It's very, very exciting research. And then after that, we puncture one puncture needle. So we get one ablation do. The size is 5.2. It's very bigger than before by use the one single puncture. So the contrast ultrasound, especially the 4D, its guidance the vessel blocking is possible and useful. Another case we can see this femur is a male case with 3 centimeter tumor is just here, and the feeding artery is very clear. By use the 4D, we can see the feeding artery 2, maybe 2 is here. So we like to cutting the tumor feeding artery here and here, just as here. And this is during is the before. You can see the feeding artery with during the feeding artery blocking, and here is after the feeding artery blocking. We can see a big area with no any more perfusion. So we are necessary to ablation the tumor anymore, because next the tumor is the stomach and the intestine. It's very dangerous for this patient. By the broken the artery, we can just like cutting the wrist area and just like resection. So after 1 month, we use the CECT to evaluate. We can see wrist area without any enhancement, and this artery phase and portal phase is very successful. And in the last, I like to say, evaluate and monitor taste and chemotherapy by use the contrast ultrasound. We use the M resistor to evaluate and follow up the taste efficacy. Firstly, we definitive the target nodule and non-target nodule, and the new nodule by just like by this picture, and we compare the nodules before taste and after taste. So we compare the contrast CT and the contrast ultrasound, the evaluate result. We can see by contrast CT, the with no perfusion, 51 nodules with no perfusion, but in contrast ultrasound, it's just 16 nodules without perfusion. So it's quite different. Which one is correct? I trust the contrast ultrasound, because all patients we have the pathology diagnosis. We can find the viable tissue in the tumor inside. So the consistent rates in perfusion is very poor between the contrast CT and the contrast ultrasound. And by use the M resist, we use the CRPRSD on PD to evaluate. The contrast ultrasound is only 9 patients can get the CR, but by contrast CT, 44 cases it's CR, so it's quite different. So the consistent rate in the treatment impact is the same pool, just like the perfusion. This is a typical case. We can see the lipidol in the liver, tumor is here, but the CT diagnosis is diagnosis is but by use the contrast ultrasound, we can see a lot of enhancement around the tumor, just here, and you can see the wash out just here. So it's complete diagnosis in contrast ultrasound, but it's complete necrosis by CECT. So according to the M resistor standard for taste, the contrast can be more sensitive to detecting the residual tumor blood supply than CECT, and the contrast ultrasound can be more accuracy assistant the treatment efficacy. The contrast ultrasound and the tumor ablation in China have used more than 12 years. We combine the contrast ultrasound and tumor ablation usually in our clinical practice. In summary, you can see the main improvement of the CEUS in our clinical practice is in it helps to make the differential diagnosis of tumor and help to locating the small tumor tissues. It may be less 1 centimeter or 2 centimeter, and it's helpful to locating the residual tissues or the local tumor progression tissues, and it's helpful to guidance the difficult position tumorous punctures for ablation, and it's helpful to evaluate and follow up the ablation infection or taste treatment. By the keywords, we can see by use the contrast ultrasound, the diagnosis and the treatment is more precise more prediction and more mini-invasive. So I like to conclude my lecture. The contrast ultrasound is proof diagnosis and treatment ability for HCC, and especially for small HCC and difficult cases. And the combination of the contrast ultrasound and its promotion the persistent development for medical science. And by using contrast ultrasound, its more precise medical service is coming. Thank you very much.
And one of our audience have raised the question: do you differentiate metastasis in lymph node in portal vein and non-specific lymphadenopathies?
Do you mean to differentiate the lymph flow in port vein?
Yes.
Oh, lymph flow in port vein. 淋巴结在静脉。
门静脉。
Yeah. I have no such experience for lymph flow in port vein. But I think the contrast ultrasound is very useful to diagnose the thrombi, the tumor thrombi in port vein. It's very helpful to the differentiation from the blood thrombi. It's very useful. For lymph node, I have no such experience, because in the liver hepatocellular carcinoma is very few to metastasis by lymph node. It's just directly metastasis in the liver or other sites. The lymph node is not the main way to metastasis. I don't know. It's right or not.
How did you occlude the feeding vessels on the to HCC by RFA electrode?
I cannot see the question. How can I see the?
How did you occlude the feeding artery to HCC by RFA electrode?
Okay. So it means how do I occlusion the feeding artery? Yeah.
Yes.
Okay. Yeah. I used the congregation model to broken the feeding artery. Sometimes if the congregation model is not effect, it's not work, I use the ablation model. It's about 2 minutes. It's enough because we have an experimental and animal experimental. We know when I use the ablation model, we can occlusion the vessel in size 1.5 is useful. So I have the confidence for that. Yeah, we have the experimental in the animal in the pig. Yeah.
Okay, thank you. Now I also have a question I wanted to ask you. For example, if the case we don't know whether they have small lesions at all, and the small lesions have not been detected on conventional ultrasound. Well, how to choose the view for CEUS to perform? It should be referred by CT or MR image.
Okay, so do you mean the tumor is detected detected by the CT or MR, but cannot detected by the ultrasound? Do you mean the situation?
Normally in China, we know
Yeah.
that the ultrasound will be earlier performed
Yeah.
prior to the CT and the MRI examination.
Yeah.
So
Yeah.
in this state,
Mm-hmm.
normally the patient have not performed the CT and the MRI,
Yes. Yeah.
and
Yeah.
the patient, we couldn't know whether the patient have tumors or not on the B mode ultrasound. Well, so
Okay.
this case, should we also perform the CEUS?
Mm-hmm. So, normally the contrast ultrasound is before contrast CT. Yeah, in China. Can you hear me? Yes. Okay.
Yes.
And so yeah. So
Yes.
maybe the patients have AFP, FP, and is rising or anything else. So we can have a 2D for whole liver, and then we use the contrast for the for the liver. We used 2 times. First time, we just use the contrast ultrasound. Maybe we cannot observe the tumor's artery phase, but we can wait for 2 or 3 or 4 minutes to observe the washout of the tumors, so we can see a low enhancement area in the liver. And after we located the low enhancement area, so we injection the contrast agent again. We take the second time of the contrast ultrasound, so we maybe saw the artery phase enhancements. It's okay.
Okay.
Thank you. Thank you.
Do we have any other questions? Well, thank you very much, Professor Xie.
Thank you.
Thank you
very
for
much.
the presentation.
Thank you
Now
very
we
much.
will move to the next topic.